Good afternoon, everybody. My name is Paul Cambio. I'm one of the co-chairs of the California Lawyers Association's Health and Wellness Committee, and we're committed to bringing programming to help make lawyers healthier. And that's why we have Dr. Mark Hammond with us today. He's presented for us before, and I urge you to go to our webpage and see our previous presentations. He presented for us back in 2025 on the blue zones. And I'm going to turn things over to one of our committee members, Gary Letourneau, who will introduce Dr. Hammond.
Hey, welcome everybody. Thanks for being here. We have a terrific presentation. As you know, it's Heart Health Month, our number one killer. And Dr. Hammond is an amazing gentleman. He's well known throughout the United States as a phenomenal medical doctor and speaker. He's the co-founder of the largest healthcare center in the South. He's a member of the very prestigious Physicians Committee for Responsible Medicine out of the Barnard Medical Center in Washington, D.C. He's now retired and he's teaching at the university level and he's available. And I've got to know him well. He's just a real gentleman and a extreme wealth of knowledge. So we're incredibly fortunate to have Dr. Hammond again. Dr. Hammond, welcome and thank you very much for being here.
Dr. Hammond, may I just interrupt 1 second? So we're going to take some questions. If you'd like to put them in the question and answer box, save them for the end, and time permitting, we'll answer those questions at the end of the program. Thank you.
Great. Thank you, Paul, and thank you, Gary, for that introduction. I hopefully can live up to half of what you said. But yes, very honored to be speaking with you. Only correction, I would say I don't really call myself retired anymore. I spend more time working now than I did in my active practice, but it's totally enjoyable because I'm finally able to teach people how to take control of their health and be healthy, which is the reason I got into medicine in the first place almost a half a century ago. This is a real great topic. Obviously, February is Heart Month, and it comes up every year that we're going to get some new data and new statistics. And I always find it amazing to me of the number of people who don't seem to understand the depth and breadth of coronary artery disease in the United States. So we'll talk a little bit about the problems first. The initial slide here is one of my heroes, Dean Ornish, who is based in San Diego, University of California, San Diego, and has done multiple lifestyle studies since the 1990s on the power of lifestyle to heal, to not only prevent, but also reverse chronic disease. So Brianna, if you could go to the second slide here, and we're going to have to do this manually because of technical glitch, but if we can pull up the second slide. So awareness, a famous person once said, you can't change what you don't acknowledge. And if you don't know something and you can't acknowledge it, you can't change it. But it's amazing to me that coronary artery disease has really been the leading cause of death in the United States for 100 years now. Originally in the early 20th century, it took the place of influenza, pneumonia, tuberculosis, smallpox. So you would think after 100 years experience, we would have gotten to the root cause. Well, actually we have. It's just not widely known, unfortunately, but it is growing in knowledge, and we'll talk a little bit about that. The statistics are alarming. Half of Americans, over half of Americans slightly, don't even know that coronary artery disease and heart disease is the number one cause of death. 12% of Americans will die directly from a heart attack, but that's an extremely underrepresented number in the fact that many comorbid conditions and coronary artery disease plays a significant role in multiple factors. And we can talk a little bit about that as far as the COVID pandemic as well, that unmasked a lot of hidden coronary artery disease. It's highly underreported. I've worked as a medical expert in reviewing charts for over 20 years now. And I can tell you in the hundreds, really thousands maybe of charts that I've reviewed, I would say heart disease plays a role in probably over half of them at least. And the death certificate only mentions it maybe in about 10 to 15%, which is why we get these numbers. I think it's grossly underreported. Next slide, Brianna. So a little bit of history, and I won't go too much into detail on this because this is not much, but history is important. We really didn't know up until Da Vinci had inklings of it, like he had inklings of a lot of things. The first concept of thrombosis in the 19th century by Rudolf Virchow. And then when we started doing, or I say we, when the medical profession started doing postmortem exams in the early 20th century, it started becoming obvious that coronary artery disease was a significant cause of mortality. The actual first coronary arteriogram wasn't performed until 1952 at the Cleveland Clinic. The Cleveland Clinic will come into play a little later with one of my heroes, Caldwell Esselstyn. But in 1952, the first arteriogram was done. The first bypass surgery was done in New York by Dr. Getz in 1960. The first cardiac angioplasty was done in 1977, just 2 years before I entered medical school. And the first stent was put in Switzerland in 1986, my first year of medical practice. So these are relatively new invasive procedures that were hopeful to have turned the epidemic of coronary artery disease around. And what we're finding is, in some circumstances, yes, but these are highly expensive procedures that have unfortunately not produced the long-term results we're looking for. And hopefully at the end of this discussion, you'll understand why. Next slide, please. So you compare us with other countries. Again, we fall short in many ways, but in coronary artery disease, Europe is a pretty good, they have pretty similar rescue models of stents and angioplasties and bypasses. So the availability of procedures like we have here is relatively comparable. They perform fewer of these procedures. They do fewer angioplasties, fewer stents, and their mortality in our country is higher, and we spend a lot more money. That's basically the gist of these slides. Next slide, please. So this is a COVID number, and I think many of you watch the news, you're probably aware that the COVID hit the United States a lot harder than it did a lot of our comparable countries. And these are excess mortality data from COVID per 100,000 people. What people don't understand is that a big driver of this was not so much underlying lung disease, which you would kind of, certainly that was a factor, but the biggest associated factor with deaths and disability from COVID were due to coronary artery disease and insulin resistance, which of course is triggered by obesity and the Western diet. And it really exposed also a lot of our racial inequalities in that African Americans were perishing at a much higher rate than Caucasians. Next slide. You probably showed this on my Blue Zones talk last year, and this is probably no surprise to anybody, but the numbers keep climbing. This is for every man, woman, and child. Our per capita spending on healthcare is way above the other countries, and we don't live. I think maybe we outlive slightly India and China. We're about par with Mexico. The rest of those countries on there have a longer lifespans than we do. So it's pretty sobering. Again, you can't change what you don't acknowledge. Next slide, please. This is some more prevalence data. This is in the United States, even from the age of 20 to 39, that there's significant prevalence of coronary artery disease. You can see with this chart that it rises with age. And I think it's important to know this. And the next slide will also go ahead and let's do the next one, Brianna, and we'll kind of show a little bit more that even at age 13 to 19, there's already evidence of plaquing in the coronary arteries, and this obviously goes up as time goes on. this is probably a good time for me to share with you some data I just read today from the American Heart Association that in the years from 2011 to 2022, in the United States, death from heart attack in the age group 18 to 54 rose by 57%. I'll say that again. Younger people, much younger than me, age 18 to 54, died at a 57% increased rate beginning from 2011 to 2022. So it's pretty sobering that younger people are getting coronary artery disease much earlier, and they're getting much more in the way of coronary myocardial infarctions. Next slide, please. So the causes, we all kind of know these. Obviously, smoking, Western diet. I put Western diet number one. It's really actually maybe even more important as smoking rates have gone down. Unfortunately, our diet has, if anything, gotten worse. And all of these comorbidities, I think most people know: high cholesterol, high blood pressure, obesity, diabetes, other inflammatory diseases, as well as sleep apnea, which is a significant driver of coronary disease as well. Next slide, please. So we all know this is the standard lipid profile that you get when you go to your doctor, a fasting lipid profile. You get the good, the supposedly bad HDL. The HDL is the good, the LDL is the bad. And these numbers are fairly well known by most people that you want your numbers less than this. This is sort of just a rough analysis, but I put these up here because we're going to get into a little more specificity about new ways of looking at risk through blood markers. Next slide, please. So the data goes back many, many years. Framingham, Massachusetts is one of the larger cohort studies where a population of an entire city have been evaluated since even before I was in medical school. And it's clear that the higher your serum cholesterol is, the higher your incidence of coronary heart disease. We know this. You may hear some stuff about dietary cholesterol not being important, and I think that's not true. The higher your serum cholesterol, the higher your risk of heart disease, and it varies. But obviously, on this chart, even going from 200 to 300 in a total cholesterol, there's a significant difference in coronary heart disease incidence. Next slide, please. Mm-hmm. And I'm going through these. I don't want to spend too much time on each slide, just because I do want to leave. This is a very educated audience, and some of this you may already know, but so I'm going to leave at least 15 or 20 minutes at the end. So try not to get too hung up we're going to get into a little bit of physiology here, so try not to get too intimidated by it. I'll try to make it simple. This next slide is fairly straightforward. And again, LDL, bad cholesterol, it's the form of cholesterol that is most involved in coronary plaquing. And clearly, as your LDL rises above 110, 130, your risk, just for an example, you can see there's just multiple times risk if your LDL is 60, which is where it really, if you look at some of the new data, that you want to get it maybe even below 50 if you can. And so this is there's clearly a linear relationship between LDL cholesterol and coronary heart disease events. Next slide, please. So yeah, this is going to kind of segue us into the next few slides that I'm going to get into a little bit of physiology. And the reason for that is for this question that I have received through the years. Doc, my cholesterol numbers are normal and I had a heart attack anyway. Why? Excellent question. And maybe that person wasn't a smoker. They didn't have sleep apnea. They didn't have any other underlying metabolic issues like insulin resistance or even prediabetes. And so that's not common. I don't want to paint this as a picture that cholesterol and lipid numbers don't matter. In 80 to 90% of the cases that I saw through the years, there was clearly a link between the cholesterol numbers. But I did get this question occasionally, and I would go through the chart and look at everything and go, you're right. Your triglycerides are normal. Your LDL is only 80 or 90. which was below threshold. All your numbers are pretty good, and you're not diabetic. You had a heart attack. Why? I think that over the last decade, we're getting a much broader understanding of how cholesterol plaques in the arteries, and it's not as simple as just getting your cholesterol numbers way down or triglyceride numbers way down. And we're going to get into some of these topics at the bottom. I've listed the ApoB, the TMAO, nitric oxide inflammation. We'll go over these one at a time, hopefully very, very simply, so we won't get into too much pathophysiology. Next slide, please. So this is a slide that basically shows you different mechanisms whereby red meat, chicken, dairy, eggs, cheese, animal food consumption stimulates multiple pathways that lead to atherosclerosis. And it's not just the oxidized LDL cholesterol. It's also the bacterial endotoxins that come not only from the food, but from the gut microbiome. TMAO, which we'll talk about in a little bit, is a separate mechanism. So this is the answer to the question from that patient who asked me, "Doc, why did I have a heart attack?" Well, I'm going to explain some reasons why everything might have looked good, and that maybe you want to get a few different things checked out besides your lipid profile. Next slide, please, Brianna. So don't get too intimidated by this. This is a two-dimensional view of a blood vessel. And at the top, that sort of grayish, light grayish area is the lumen, or the opening, the channel where blood goes through. The intima, if you see right below the word lumen, the intima is the layer of tissue, the cells, the endothelial lining that forms the very most superficial lining of the blood vessel. So what happens is, and through multiple factors of cholesterol, through inflammation, through oxidative stress, the cholesterol causes disruption in this lining. And so it's a really important concept to understand chronic disease, because this is true for stroke. This is true for many forms of cancer. It's true for dementia. The ground zero stimulus is chronic inflammation. We could have a separate discussion. I've got a separate PowerPoint on inflammation that gets into some of the details of how this actually occurs. But this lining, you can see that arrow from the monocyte going through the cell is an injured part of the wall due to inflammation and due to other multiple factors. What happens is that monocyte takes up the cholesterol. As you go toward the right of your screen, it forms what are called foam cells, which are sort of the ground zero of plaque formation once it gets to that point. And that's just a cell that is loaded with oxidized low-density lipoprotein cholesterol. Next slide, please, Brianna. Another cross-section, and this slide is going to give me the opportunity to explain something that you may not be aware of. Actually, some doctors aren't aware of this, but this is a cross-section of a blood vessel. And so all these little frisbees going through here are blood cells, red blood cells. And so naturally, you'd like to have that completely open and clean. As you start with a fatty streak, you go to the bottom of that slide and look as far left as you can go, and you'll see fatty streak. That is the beginning of these foam cells accumulating in the wall of the blood vessel. And as we go toward the right, what you see is this sort of organized glop of fat that might look like something you trimmed from your steak years ago. If you ate steak, if you still do, please. That looks, and it looks for every bit, and you see this grossly in gross anatomy. It does look like the fat you're eating from animals. If you'll notice, right above this glop of yellow plaque, you'll see what's called a fibrous cap. It's that white. It's right below the white. It's the lining of that thrombus, or that, not that thrombus, but that plaque that forms as the body develops these plaques. And so you might ask the question, this artery looks about 40% blocked, right? You might ask yourself the question, which artery has a greater chance of causing a heart attack? A 90% calcified lesion or a 40% non-calcified lesion? And the answer is B, 40%, because this fibrous cap, until it develops some tensile strength to it, is very vulnerable to rupture. And when you see on that slide where it says plaque rupture, that's where all this plaque goes out in and causes a thrombus, and that is the genesis of a heart attack. So it's a good explanation also, and it's a good point to make here. And it's people wonder, why is it that we've got all these procedures that dilate the vessels, put a stent in around a 95% lesion or whatever, and open it up to 100%? Why is it that doesn't confer long-term survival improvement? Why is that doesn't confer long-term quality of life? The statistics on stents and bypass surgery and just garden variety medical therapy for stable blockages is virtually the same when you look at it over a decade. So these procedures haven't really improved longevity when it comes to stable coronary artery disease. Now, I need to be real clear about this. Stents and bypass are extremely useful and life-saving in the event of an acute myocardial infarction. In that situation, it's time to get fixed before you go onto the lifestyle, and that will confer significant saving of muscle. So we're talking about two different populations here. The one patient that comes to you who says, Doc, I'm having chest pain when I walk up my driveway, and it's new and it relieves when I get rested. He gets a stress test, he or she gets a stress test. It's positive. They go to a cath and they've got multiple moderate lesions. That's the patient that stents have not proven to be valuable, or bypass, as far as compared to medical management, and certainly way inferior, in my opinion, to lifestyle changes. In the event of an acute myocardial infarction, that's a totally different story. It's valuable in that setting. Next slide, please, Brianna. So briefly, you may have heard of what's called ApoB, or apolipoprotein B. This is sort of the new buzzword in cardiology and even in primary care. These levels are being checked more and more because it's felt. I've heard several lipid specialists and researchers talk about ApoB. It is the primary carrier of every LDL particle. So the ApoB is a more direct measure, if you will, of the risk factors. So it's considered to be a test that is probably more predictive of coronary artery disease risk than the actual LDL cholesterol. Right now, I don't think it's covered by a lot of insurance. The last time I looked, I think the cost is somewhere around 70, 80, maybe $100. But it is something to think about. And I think as time goes on, the ApoB will be a test that we'll be ordering more of. Next slide, Brianna. So this is just sort of an ApoB analysis over a population. It does tend to mirror the LDL. So in other words, if your LDL is around 100, in most people, it's going to be about 20% or so, something in that ballpark, less for your ApoB level. But any level greater than 97 on this chart, and this I believe came from the Framingham data, puts a person at risk, because you're actually measuring the worrisome particles, the worrisome LDL particles. Harvard study showed that less than 60 should be the target, and certainly that's ideal. And it is certainly possible with lifestyle changes and maybe or statins, let's put it that way. But it can be done in many people with just lifestyle alone. Next slide, Brianna. You heard me talk about inflammation earlier. And inflammation is the driver of virtually all of our causes of chronic disease in the Western world. And it does so primarily through lifestyle. I would say diet is the main component. Obviously, being sedentary increases in chronic inflammatory markers. Stress levels obviously can do it too. All aspects of lifestyle, but certainly food is the biggie. And eating the American diet, the SAD American diet, SAD, Standard American Diet, is extremely a pro-inflammatory diet. Rich in processed carbs, meat, dairy, eggs, and obviously cake, candy, pies, all those dessert treats can raise your CRP. These are the levels, the target levels, the high sensitive CRP. Again, I'm not sure. A lot of cardiologists do check this now routinely. I think this is probably more covered depending on your insurance. Next slide, please. And so inflammation, as I mentioned, is a driver of virtually all chronic disease. Obesity in and of itself is sort of like a feedback loop with inflammation, in that inflammation can drive obesity, obesity can drive inflammation, and you get into this just vicious cycle. But inflammation is really the missing link with a lot of people. And so a lot of cardiologists will tell you that they check the high sensitivity CRP and really try to aggressively address inflammation, not through medication, but through lifestyle. Next slide, please. TMAO, what is that? So this is something you may or may not have heard of. This data, I think, was published in Circulation, the Journal of Circulation, in 2018. This is another pathway by which animal protein, not animal fat, but animal amino acids, can lead to atherosclerosis. And so these three amino acids you see on this chart with L-carnitine, choline, and lecithin are three amino acids that are the precursors to TMAO. But it's an interesting loop here, and bear with me just a second and I'll walk you through it. Consuming a lot of these animal products over a long period of time causes what we call gut dysbiosis. So in other words, bacteria have to develop in the gut to deal with these animal proteins and fats. And so over a period of time, the gut microbiome becomes dysbiotic. Don't let that word mess you up. Basically, bad guys that cause inflammation, but also metabolize these three amino acids into TMA. Now, TMA by itself is not harmful. Doesn't do anything for atherosclerosis. It has to be oxidized in the liver. That forms TMAO. TMAO promotes other inflammatory diseases as well as atherosclerosis. Interestingly, if you take a vegan who's been a vegan for over let's say over a year, and their gut microbiome is much healthier than the carnivore, and you feed them steak for a week, they will not form TMAO because their gut microbiome hasn't had a chance to form the bacteria necessary to convert that into TMA, that second era there. So it's a combination of eating the animal protein, and it's also accelerated by the gut microbiome. So it's incredibly important to have a healthy gut microbiome, which you get from whole food, plant-based foods. Next slide, please, Brianna. So one of the amino acids I mentioned, L-carnitine, I see these I won't go into that. That's a negative comment, but some trainers are real big on these massive protein diets, and so you only can get 200, 300 grams of protein. You know, we're in this protein is everything now venture, and it can be very harmful. And so all of these foods produce L-carnitine, which through the gut microbiome can form plaque. So yes, you can get coronary artery disease without the LDL cholesterol coming in. Next slide. Just a brief thing about what elevated TMAO levels are also not only with cardiovascular risk, but diabetic retinopathy, cognitive impairment potential, and bone health. Next slide, Brianna. So this is data on TMAO levels and looking at the numbers of heart attack, stroke, and death over a period of 3 years. And this shows a pretty linear relationship to your TMAO level in your blood to your risk of myocardial infarction, stroke, and death. And what you see is a roughly threefold increase from quartile 1 to quartile 4. In other words, the 25% that had the highest TMAO levels had a 3 times risk of myocardial infarction, stroke, and death over a period of 3 years. Next slide, please. So what is a good TMAO level? I mean, these are considered goals. Your goal will be less than 5 micromoles per liter. Greater than 7.5 would be risky, and the others would be borderline. Again, I think this is a test. If you see a functional medicine doctor, some of the doctors that love to test everything, you might find that you might have gotten this test before, but just going to your regular primary doctor, you probably haven't gotten this checked. But it is another explanation back to that question, doc, my cholesterol is normal. Why did I have a heart attack? Again, TMAO is a hidden factor. Next slide, please. Nitric oxide, again, you may have heard of this molecule. It is a signaling molecule that is a potent vasodilator. It's present in that endothelial lining of the blood vessels. It's one of the tricks that Caldwell Esselstyn figured out early in his research, that the more you stimulate nitric oxide, the more those blood vessels open up. And it's a great thing. It's no longer hidden. Most people who really have studied a little bit about nutrition know that having more nitric oxide in your system is important. It's a hard thing to test because it's not in the bloodstream for very long, and it has a very short half-life. Next slide, please. Foods for promoting it, and really all of these will do it. I'll give you the thing that Caldwell Esselstyn did early on, and it sounds pretty aggressive, but I guess if you have a Widowmaker, you probably would do anything he says, and believe it or not, it's massively works. But he had his folks cooking a number of different types of leafy greens and adding balsamic vinegar, which has acetic acid, which promotes the release of the nitric oxide. But all of these foods are heavy nitrate components. And what this does is it creates a massive vasodilation. He has people eating this 6 times a day. I haven't found too many people willing to cook greens 6 times a day, but there's probably easy ways to do it. Gary raised his hand. There you go, Gary. You're the man. I do it at least a couple of times a day, and I just use a lot of greens. And it's amazing how greens cook down. It's not as much to eat as you think it is, but the acetic acid from the balsamic vinegar really does a thing and promotes nitric oxide release. All plant-based foods, many of them are strong nitrate components that will promote the release of nitric oxide. Next slide, please. You may have heard, we're not going to spend too much time on this because I want to get into the good stuff. You may have had a CT calcium score. I did numerous stress tests through the years on people with a CT calcium score of greater than 400 who didn't turn out to have much of anything. Really, this test, its negative value is more valuable than anything. If you have a calcium score of 0, it means there's no detectable calcium in your coronary arteries. So a number of 0 is good. If you have minimal to moderate calcification, it's difficult to really make a prediction on that. But certainly, as your number goes up, you do have a higher chance of having advanced coronary artery disease. Next slide, please. I did these. I've probably done, I think I counted up at one time after I quit doing stress tests, I'd done probably over 10,000 of these. I'm always partial to it because it's where I met my wife. She's a treadmill nurse, and so we met in the treadmill lab. It's a good Valentine's story, and for February. But so I was a supervising physician, and we either did chemical stressing or walking, and it's a good test. It's not perfect. It can miss things. And so it's typically paired with nuclear imaging before and after the test that gives it a bit more sensitivity and specificity. Next slide, please. This is just the EKG changes. The one on the far right is the one you don't want to have, where your EKG shows a change in sloping and goes below the baseline greater than 1 millimeter. That's considered a positive stress test. Next slide, please. The good stuff. I got the book right here. This book was published almost 20 years ago. And Caldwell Esselstyn is a fascinating man. If you ever get a chance just to read his story, it's just incredible. He was an Olympic gold medalist in 1954 in rowing in Melbourne, Australia. He's one of these guys that is just obviously born to lead. And he was a combat pilot in Vietnam on a war. I think he won the Bronze Star in Vietnam. And came back to the Cleveland Clinic. He trained at Case Western Reserve and was president of the medical staff for a period of time at the Cleveland Clinic, which is one of the most renowned heart centers in the world. Just an incredible guy. He's still going strong at age 93 and still eating those greens, just like he did, just like he prescribed to his patients. Next slide, please. And Dean Ornish, one of my heroes, who applied all of the lifestyle, not just the food, but the meditation, the yoga, the stress reduction, the movement, the 30 minutes of walking a day, and the community support from the group. And this was published in 1998. And we'll go into the results briefly, and then I'll conclude. Next slide, please, Brianna. This was the original study. Amazing stuff. His 82% of his subjects in the first year showed reversal of using his lifestyle plan, and these were folks with known coronary artery disease, and he was showing clear reversal. This was back in the 1990s through radiographic analysis. And the real cool thing about this study is if you carry it out even longer, it becomes even more impressive. I think it's 88% at 5 years. Really, really inspiring stuff. And this study has been around for 30 years. And, fortunately, his name has become more popular as his prostate cancer and dementia studies gain some press as well, using the same basic lifestyle. Next slide, please. This is the 4 pillars. I love the way he simplifies it to eat well, move more, or eat well, stress less, move more, love more. It's pretty straightforward. Next slide, please. This is what an Ornish diet looks like. This looks pretty similar to what I eat. It doesn't have the oats on there with all the stuff I put it in the morning, but the food is great. I mean, I tell people all the time when I started eating this way 10 years ago, I eat more food than I've ever eaten in my life, but it's all prebiotic dietary fiber that is reducing my systemic inflammation markers for sure. So it's a very tasty diet as well as an effective one. Next slide. So we'll conclude with the father. I would call him, and Colin Campbell, the fathers of nutritional science in this country. He started his program in 1985, and he took 24 patients. And these were patients with advanced coronary artery disease. And I think, let's go to the next slide. I think it's got some of the data on there that we can drill down on just a little bit. Yeah. So 1985, 24 patients had advanced coronary artery disease. These were people who had been through angioplasty, stents, coronary artery bypass graft, unstable angina. These were people who had nowhere else to go. 3/4 of his original study group, 3/4 of these people had had an average of about 3 of these events per person in the prior year. That's in their medical history. That is incredible. That shows you the advanced nature of he took on the worst of the worst, and he really got aggressive. I would say maybe even a little more aggressive than maybe what lifestyle medicine would teach today. But if you've got a widowmaker, I think you're probably going to do anything you possibly can do to reverse. So he basically had all oils, including plant oils, were eliminated, including avocados and nuts. He didn't allow any fat whatsoever, although there's omega-3s. He did make an exception there. But his data is unbelievable. It really is one of those things that people, I don't think, really believed, but it's true. He had basically the average patient in these 24 reduced their serum cholesterol from 240s to an average of 246 to 137. Angiograms documented widening. Most symptoms disappeared in 8 to 12 weeks. And the most amazing thing of all is the third line from the bottom there on the slide. None of them, 0 of the 24, experienced a cardiac event in 12 years of follow-up from 1985 to 1997. And that's when his work at Cleveland Clinic started really accelerating. And it took him another 10 years after that to write this book that I pointed out earlier. Next slide, please. This is actually a colleague of his, I believe, who came to him in 96. I believe as an internal medicine doctor, as I remember. I could be wrong about that. But his lesion in the distal LAD, you can see on the left slide there, was too long to be stented. And so he was extremely depressed. He came to Dr. Esselstyn, and Essie, as they call him, and said, I'm really depressed. There's nothing people can do for me. And Dr. Esselstyn, of course, said, join my program. And you can see 3 years later, that looks like a perfect LAD of a 25-year-old who runs marathons. Next slide, please. So we are getting closer. You know, when I really started getting into this 10 or 12 years ago, into my 50s, I was kind of an outlier. It's one of those things that you see coming your way. One of the 3 or 4, I think it's 3 or 4 years ago, the past president of the American College of Cardiology, Dr. Kim Williams, is very much on board with everything I'm telling you. He is a former president of the American College of Cardiology. The keynote address for last year's conference at the Physicians Committee for Responsible Medicine was the incoming president of the American Medical Association. And this coming August, I'll make a plug for that conference if you ever want to know about nutrition and medicine. It's called the International Conference on Nutrition and Medicine. It's every August in Washington, D.C. The speakers are incredible. The food is amazing. It will show you how great the food is. And it's growing. And so at this year's conference, the incoming president of the AMA will be giving the keynote address. 2 years ago, I think it was 2 years ago, we had the editor of The Lancet, which is probably the most prestigious medical journal in the world, basically telling us, you guys have been on the forefront of this and keep doing what you're doing. So Medicare does cover Ornish's program, believe it or not, and that's been true for about 15 years now. ACLM, the American College of Lifestyle Medicine, is growing in membership. It's now 20,000 strong. Lifestyle medicine is gaining in practices across the U.S., and I'm sure you've got many more choices in California than I have in Alabama, but that's typical. And I'll put in a plug for the Physicians Committee for Responsible Medicine, PCRM. And by the way, attorneys can be members, nutritionists. We have over 17,000 physician members, over 1 million members worldwide, many nurses, educators, teachers, and attorneys, and are part of this organization. It's a great wealth of information. Dr. Neil Barnard started this 40 years ago, and he is truly one of my heroes, and up there on the Mount Rushmore with Dr. Ornish and Dr. Caldwell Esselstyn. Next slide, please, Brianna. I think this is the last one. And so basically, I just wanted to circle back that what is lifestyle? Most of lifestyle medicine is what you eat, how you manage stress, how much you move, and how much you love and support you have. And, Dr. Ornish talks about that fourth pillar, that how much community support, and he really believes in both his cardiovascular study, his reversal of early prostate cancer, and in his dementia study that showed reversal of Alzheimer's in 40% of his test group, and reversal of symptoms. Imagine, published in 2024, that he really does believe in community support. That's a huge factor. Movement is important. We didn't touch on exercise too much. I'll just tell you one statistic that'll put it in perspective for you. A 20 to 30-minute walk a day at a moderate pace will reduce your chances of a heart attack or a stroke by about 50%. So yes, movement matters too. So it's not just what you eat, it's how you move, it's how you de-stress. Look, I've worked with a lot of lawyers through the years. I know you guys are in a adversarial profession, and I have lots of compassion for the work that you do. You really have to find a way to de-stress. For me, it's been Art of Living mindful meditation that I do every single day for at least 30 minutes and usually closer to an hour. It's breath work. I know how it's working in my system, and I know that it's reducing my inflammatory markers. And so it's not just about heart disease, it's about all chronic disease that we have a golden opportunity to reverse if we'll just get on board. So I'll conclude with that, and thank you for your attention.
Thank you, Dr. Hammond. I'll read the questions off if you're ready. The first one I'm going to go to is people have asked for if there can be copies of the slides. There isn't, but we tape this and it'll go on our webpage so you can watch it as many times as you want. You just have to give us a couple weeks to upload it. So then I'll go to the first question is it okay to use coconut oil? Does it contribute to heart disease if used in cooking? And I think all oil is bad, right?
Well, coconut oil is a saturated fat. Plaque is made of saturated fat. I will say I do believe it is a significant improvement over saturated animal fat. I kind of would, it's maybe not a proper analogy, but I might say a store-bought processed veggie burger versus a full meat burger. I would say for sure avoid coconut oil. I really do believe it's one factor as to why people in India do have a pretty high incidence of cardiovascular disease, and yet they don't eat a lot of meat. They do a lot of oil, especially coconut oil and ghee. So they're vegetarians. So there's a lot of saturated fat that probably needs to be avoided across the board. Now, some saturated fat is okay if it's there's a tiny bit of saturated fat in nuts and seeds that contain rich sources of omega-3. So on balance, wouldn't say eat a lot of those things, but certainly I would highly recommend omega-3 fatty acids, plant-based versions, chia seeds, flax seeds, hemp seeds that are rich in omega-3s, walnuts, of course, any plant-based, because fish are the thing that everybody always puts out there, and it may be one of the questions. I always get questioned about fish. Fish are the middlemen and women. They don't make omega-3 fatty acids, and it's the only real positive thing about fish, other than they have a lot of protein, which we don't need as much as we're getting. So I would say coconut oil, thumbs down.
All right. Thank you very much. Next question is, what is serum cholesterol?
So cholesterol is a blood fat. It is necessary. It is part. So our livers make it. Some of us make it much faster than others, but it is a molecule. It's similar in the steroid or testosterone family chemically, but our bodies make a fair amount of this. It makes plenty of it to sustain cell function. The problem is, of course, with the advent and the increase of the Western diet, especially beef, pork, dairy, and other sources of animal fats and eggs, that cholesterol has risen in American life over the last 100 years, as has sugar, as has processed sugar. So I don't want to give processed sugar a break on that. But yeah, cholesterol is just a molecule in the body like many others. We need a little bit of it to sustain cell function.
Great. The next question is, what is a good resource for me to really learn about how to bring inflammation down? It seems like there are a lot of folks out there trying to make a buck with no real info to offer. Is there if it's ground zero for all these things, I'd love to learn more about it. That's
a great question. That is a terrific question. I'll give you a couple of things. Gary probably can give you a couple of suggestions too. I love Undo It, which is a recent book by Dean Ornish, which goes into the whole aspect of lifestyle. It may not be specifically related to inflammation, but everything he's talking about in that book as a to-do list is an anti-inflammatory remedy. Michael Greger, anything on nutritionfacts.org is just absolute gold. It's a free website. If you have a question about any topic, go to nutritionfacts.org, push the search engine, and ask your question or topic. If you want to know about vitamin B12 or whatever, he'll tell you in a 5-minute video and show you all the science behind it. We didn't mention, this may be in the question, do I believe in any supplements? B12 is one of those things that is very difficult to find. You have to intentionally eat a lot of fortified foods, of cereals and nutritional yeast, but typically the easiest thing to do is to just take a multivitamin with B12 in it. I do believe in supplementing with vitamin D, especially in those people who don't live in California and get out in the sun a lot. That's another thing. And, omega-3s, if you don't eat a lot of flaxseed or chia seeds or hemp seeds, is another to consider. There are others that probably do have some benefit, but those are the basic ones.
All right, excellent. Next question is, what causes aneurysms?
So aneurysms are a little bit different. They're a weakening in that blood vessel that I showed you in two-dimensional. It's where the wall of the blood vessel weakens and expands like a balloon. Cardiovascular disease and endothelial, or what we were talking about, that level of tissue, the layer of tissue that is the first layer you come to when you start dissecting a blood vessel, gets inflamed and becomes weakened because of oxidative stress. And so an aneurysm is just simply a balloon bulging out of the weakening of that wall. And these, of course, can rupture and cause sudden death. Hypertension, diabetes, obesity, everything that I've talked about is a risk factor for aneurysms. Once they get to a certain size, for instance, in the abdomen, if it gets beyond 4-5 centimeters, typically vascular surgeons recommend that they be repaired.
Thank you. All right, the next question is, what are your thoughts about statins? When and at what age to start, if at all?
Yeah, I'm not anti or pro statin. All the data of all the drugs I prescribed in 40 years of medicine, I'm probably the proudest or the least defensive, let's put it that way, about statins. I think they've been remarkable in their ability to not only reduce total serum cholesterol and LDL substantially, but also to reduce systemic inflammatory markers. Many of the things that lifestyle medicine does, statins do. Now, there's issues with potential cognitive fog and maybe dementia and all these other things. That's never been scientifically proven to my satisfaction, nor to any of the doctors that I follow. and you got other things that there's potentially a somewhat increased risk of type 2 diabetes. The mechanism of that I don't think has really been worked out yet. On balance, for most people, they are beneficial. However, I do not believe in them as a first-line therapy for anybody, unless you're one of these familial hyperlipidemias where your cholesterol is 600, and clearly there are a percentage of people who are genetically programmed to make cartoonish amounts of cholesterol. For those people, it's obviously important. For most people, I would say I would take at least 90 days of aggressive Colin Campbell, Caldwell Esselstyn, Dean Ornish, Michael Greger approach to your life. Recheck it again in 90 days. And if you're still above where you want to be, then I think the statins are the way to go.
Okay, great. What about supplemental probiotics and prebiotics in relation to gut health? Are they good or?
Perfect. Great question. So I'll take the prebiotics first. Prebiotics are simply dietary plant fiber. There's no prebiotic fiber in any animal food or any processed sugary foods. Prebiotic fiber comes from fruits and vegetables, whole grains, nuts, seeds, legumes, beans. Those are the fuel for the good guys, if you will. It's almost like we have this good guy, white hats, black hats, bacterial war going on in our gut. The more plant fiber, prebiotic fiber we eat, the more those good guys will naturally take hold. And so taking probiotics and still eating a crummy diet is worthless. I do think there will be a science of this that's evolving. There's some interesting work at Johns Hopkins going on now about rewilding the gut through a series of probiotics. But at this point, buying anything over the counter or because of any claim or anything, I don't believe in that. I think if you feed your gut prebiotic fiber, everything downstream is going to take care of itself.
Excellent. Are carotid artery ultrasounds worthwhile to monitor coronary disease?
It's indirect. It's not a direct correlation. There are people with advanced coronary artery disease with clean carotids and the other way around. I think it's a great question because it segues into a brief discussion about what atherosclerosis looks like. And it's not just one blockage here, one blockage there, one blockage. It's a diffuse process, if you will. Carotid ultrasounds are simple. They're non-invasive. They're easy to do. It's not as I don't think as a routine screen. It technically has that much value to the blood markers. But just because you have clean carotids does not mean you necessarily have clean coronary arteries, and vice versa. They do go together a lot, but the smarter approach is to try to reverse anything that's there. And as far as what you monitor, to me, the things that I've mentioned in the talk, and still the LDL is probably the gold standard. It probably be replaced by the ApoB, but that's your best, and your inflammatory markers, as I mentioned. Your blood markers probably are going to tell you as much as anything. Now, if you're having symptoms and this isn't just a preventative screen where you're going to a doctor and getting a bunch of tests just to screen, that's a different clinical situation.
Okay. And then we had someone make a comment. Please mention that even 10 minutes of meditation is good. Would you?
Oh,
agree?
amen. Please. And I don't, if I said 30, if I don't listen to me, if I'm saying I do close to an hour a day, but I have worked my way up to that. And believe me, nobody knows more than a doctor or a lawyer how hard it is to shut our brains off and get into our true self. No matter what spiritual path you're on, there is a place in us that has this intuitive. I listen to the physiologists, the scientists who understand the quantum physics and the universe started from a low entropy state. you can take that corollary that our creativity, our intuition, our true valuable knowledge comes from a place deep inside of us that is best accessed when we get into a place of meditation. So yes, yoga, meditation. Here's the thing, Ornish's program, this is fascinating. This is fascinating. I mean, this is one of the reasons why I upped my game when it came to meditation. He has his folks doing an hour of meditation a day and walking 30 minutes a day. We always think about exercise, which is important, but obviously based on that ratio, he considers meditation time twice the value of walking, which is very interesting to me and caught my attention. Some of the data on meditation and chronic disease is very interesting, and I don't claim to be an expert in that. I'm a student in that.
Okay, great. Then we have someone who says they're a person from Africa and they enjoy eating palm oils. Is that an issue of moderation? And what do you think? No oils, right? No added oils, no reason.
Yeah, palm oil is not great. I mean, it's again, I hate to say moderation. Carl Esselstyn famously uses the word, or actually, Greger says it better when he says moderation in all things gives you moderate disease. So I'm a little skeptical. I look, if you're cooking in palm oil, I would look, and if you're African-based foods, and this is a passion of mine now, is getting culinary African foods into the African American community as a culturally relevant food to them before they came over in ships, right? And it's a matter of pride. It's not the grease. It's palm oil, and maybe palm oil has some degree of African origin, but Africans, they don't eat barbecue and hot dogs and hamburgers. And so when I hear people saying that African Americans are genetically predisposed to coronary artery disease and type 2 diabetes, it's BS. And I hear Oprah go on CBS Sunday morning saying she's genetically programmed to weigh between 211 and 217 pounds. I just want to throw up. As much as I have always respected her so much, that's a damaging thing to tell people because it's false. The reason she said that is because calorie restriction didn't work for her. Well, it doesn't work for anybody. The whole point here is to get people back to eating off the ground, out of the ground, fruits, vegetables, nuts, legumes, and find creative ways of spices, of herbs, of seasonings that are indigenous to African communities that will make the flavor. It may not give you the same opioid feeling that maybe oil will give you, but it will give you, it's a much more interesting dish. And so culinary medicine has really taken off. I give PCRM a lot of credit for creating this Food for Life program. And we are really working down here in the Mobile, Alabama area of getting African-American culinary medicine into, as a matter of pride, just like PCRM did with the Navajo Nation. And many Navajos now are back to eating their cultural foods because of the initiative of the Physicians Committee for Responsible Medicine. And the leader of the nation has become a plant-based eater and is a huge advocate. And it's not only a matter of, hey, I'm not diabetic anymore. I don't have heart disease anymore, but it's also retaining a sense of cultural pride that I think is really important, because I think a lot of people down here in the South think that their cultural foods are fried chicken and barbecue. Those are your enslavement foods, and they're enslaving your body. We need to be getting back to your cultural origins. So the question from the interested party from Africa, I would say, limit or eliminate the palm oil and find other ways to season your food and make it more interesting. It'll be more interesting, and you won't feel as full after you eat. You'll feel energized. Oils tend to constrict those blood vessels, and by that nitric oxide, palm oil will cause nitric oxide to diminish. So you want to do everything to make those blood vessels as wide and as open as possible. especially as we get older, we want those blood vessels in our heart and our brain and everywhere else to stay good and wide open.
Okay, we'll do one more and then we'll let you go. What is life like post CABG?
Post CABG, coronary artery bypass grafting, and what is life like? Well, I think it depends. There's a lot of people who get depressed. And then I don't think anybody ever really has determined why. You're on a heart, you're obviously your heart and lungs are being on a machine for over an hour. And so there's medications you take. There's a recovery period. I have found many people who underwent coronary artery bypass grafting who adopted an extremely healthy lifestyle, who have lived extremely long, productive lives. And so, again, it depends. I think it's a rescue model. I mean, my father, when he was younger than me, had a heart attack and had an emergent coronary artery bypass graft. And, Dad never was the same, but he lived another 12 to 14 years. And I think it was partly because of the bypass, because it was a heart attack and he was preserving heart muscle. The point I was making about bypass grafting not increasing lifespan is really for the patient who has moderate to severe blockage but is not actively having a heart attack. Those are the two different groups that I want people to understand. I'm not against the rescue of stenting and bypassing, in the setting of an acute emergency.
Great. Thank you. I just want to remind everybody that this program is being videotaped. It'll be on our webpage. Give us a few weeks to upload it. You can see all the slides again. You can watch as many times as you want. I want to thank Dr. Mark Hammond for presenting for us again. Again, if you want to look at his presentation on blue zones, that's in our 2025 series. So you can see him again if you'd like. Dr. Hammond, thank you so much.
Thank you very much for the opportunity. I really do appreciate it. And God bless California.
Gary, I think you're on mute if you're thanking us. Okay, that's good enough. Thank you, Dr. Hammond. Thank you, everybody, for joining us.